Guys, this Wednesday's teaching. This is the talk is about statistics, and we've run already a couple of hot seat sessions. Obviously, statistics is a massive topic. You could spend days and days lecturing on it. And David's kindly taken this task of trying to summarize some of the statistics topic in a short presentation. He obviously won't not be able to cover everything at all, but we'll try to cover more topics in the hot seat sessions. Also, we're blessed with having Shwan again with us and other mentors, Athar and Ramesh.
Actually, Ramesh and Athar have sent their apologies. They're both called away.
No worries, thank you. So go ahead, please, David.
Okay, so thank you, everyone. I'm going to talk about statistics. I think I got the short straw, but admittedly, I volunteered to do this. Sorry, excuse me. Go back up. All right, can you all hear me properly, I hope?
Yes, we can hear you very well.
Okay, so as Firas has said, statistics will come up. It is quite a big topic. You'll see quite a lot of people getting it easily wrong, but it is actually quite easy to get. There are lots of definitions that you need to know. I can't stress them quite hard enough. Things like sensitivity and specificity. But we'll try and cover those. What I'm going to do is go through this more as a way of how I learned, so by questions. And one of the best questions I found, questions that came up commonly in the exam, was from the Oxford slide presentations on the Oxford basic science thing. I'm going to start off with how do you go up setting up a clinical trial. This can be started in any different way. One of the things,
David, were you supposed?
I think this is a question. So one of the hot seat questions that Shwan asked. Tell me about the last research project you were involved in, and this is almost a prompt to say, talk about how do you set up a clinical trial. And this little diagram does show quite clearly what the things they want you to talk about. So in principle, there are four key things. PICO, we call it PICO. So patient or population, the intervention, comparison, and outcomes, preferably clinical outcomes in our situation. So we need to identify a problem or thing of interest to be studied. This could be, we do a bit of literature research first to work out what the gold standard is to compare to. And we also want to ask the question, what are we trying to prove, and also ultimately the null hypothesis. Then we design our study, we look at our population that we want to talk about, and we talk about how we're going to do a methodology of it. We may also employ a statistician, because we're not statisticians, to do a power analysis to work out the amount of people that we need to, the amount of the population we need to make sure this is relevant to be applied to the population as a whole. We also want to define the outcome, what is positive, what is negative, and we also need to look at getting ethics approval. Most trials, if you've been involved in the trial setup, this is what we'll go through. We also now talk about registering a trial, much like we have to register an audit when we're doing an audit, paper trail at work, and again, how we conduct, and then we conduct the trial, collecting our patients and also analyzing our data and collecting our data. Then you display your results, whether it be a post presentation or a paper in the JBJS if you're lucky enough, and hopefully this is something that will create a change in clinical outcomes. Okay, sorry about going through the apologies about this. So then they might ask again the things that, what is a hypothesis, seeing as you mentioned the hypothesis. So in reality, they want to know that is the statement of the assumption that you're making that whatever you're testing is going to happen, whether it is true or not. Ultimately, the null hypothesis is the primary assumption that the difference that we're seeing in our trial is occurred purely by chance. That is what they want you to say. That is the key definition in that situation. And generally, we conform a study to disprove the null hypothesis and reject this null hypothesis. So we want to show that there is a statistical difference, why we're doing this intervention. So hip replacements work, for example. Another question they might talk about is what we've discussed earlier with Amjad. Talk about data and central tendency, and what is dispersion. So in this situation, we're talking about mean is the average of the data set. Median is the middle value. Mode is the most frequently occurring value of the data set, and a normal distribution, they're all equal. So I don't know if you can see that line there. So this is a lovely Gaussian curve with a bell shape, and that's what they're talking about in terms of normal distribution, where everything is equal. And dispersion, we're asking about what is the variability of the data set. If all the values are the same, dispersion should be 0. And there are various ways of looking at the dispersion in statistics, talking about quartiles, standard deviation, and variance. For a set of data, the range equals the lowest and the highest numbers. And again, that's something they may also ask. So these are all questions they'll try and build in, and the basic stuff they want to know from terms of statistics. And they might press you a bit if you're doing well and ask you about when do you use a parametric test, and when and why you use a non-parametric test. So parametric tests are statistical tests. We use data that is on Gaussian, so normal distribution. And they're more powerful than more normal non-parametric tests that should be used on that non-parametric data, where the data may be skewed positively or negatively. So that previous diagram I showed you, the curve was a nice, lovely bell-shaped curve. You might have a skewed data where it's more towards the right or more towards the left, and that will be your non-parametric data. So focusing on non-parametric data, we know from the Gaussian distribution, it might be like, for example, height or weight. It should be follow a pattern of a population. So you'd expect most people are going to be around the average weight. We say 70 kilos for a male, maybe 65 for a lady, for example. The consequence of using the wrong data set, what happens if you use the wrong test? So the consequence may be the wrong test depends on the sample size. If the sample size is too large, you can maybe get away with it. However, if the sample size is small, the results of the data, the p-value, are more going to be likely to be inaccurate. Okay. And I think this is also a very common question. We touched on this in the hot seat questions, talking about systematic meta-analysis and systematic reviews in terms of Sackett's level of evidence. So this is what they want you to talk about when they're discussing that. Think of that pyramid triangle in terms of the levels. So I don't think we have meta-analysis in this, but this is the gold standard in terms of it's a mathematical and statistical analysis of the combined results of 2 or more studies, typically randomized control studies, where the hypothesis will address the same hypothesis in the same way. So it's got to be marrying up of different studies that are very similar. In that way, you get a larger population, and hopefully you have a better ability to hypothesize that what's happened in those studies is going to be represented in the normal population. Then you have slightly lower levels of Sackett's level. So you've got your systematic reviews, the critical array appraised, and those are an overview of primary studies. They don't necessarily have to be randomized controlled trials. They can be cohort studies or observational studies, but they tend to be the same level as the study level. So if there's a systematic review of randomized controlled trials, then they'll be the same level as randomized controlled trials. If there's a systematic review of cohort studies, they'll be the same level as cohort studies. It's something just to remember. And these are sort of the key things. Again, back expert opinion down at the bottom. They may ask you again, why is expert opinion important? So we have to accept that we've got some very senior experienced surgeons who are out there, who know their view, who have got a very good view, and we do value their opinion because they've seen trends come and go over their career. Another popular question is, what is bias? And no, it's not the referee was a Liverpool fan last night. So, I mean, that is the flaw that is built in any study. There's going to be impartiality that's introduces error into any part of your study from selection through to publication. So selection bias, that's something that we will come across. we're going to have a non-random selection of patients for a population, because patients will select themselves sometimes, because they're the ones who want to come and have a hip replacement. We're not going to go around saying, do you need a hip replacement? Or people say, no, but I'll have one anyway. Then we've got the experimental bias. So this could be reduced by randomization. And also experimental bias, again, errors in classification, for example. Are we getting our data correct? Observational bias, so errors in completing hip and knee scores. This can be done by the person filling in the form, either the patient or the physio or the doctor doing it. And again, we also have to remember that people have 2 knees and 2 hips, so adjacent pathology can skew the score. So although we're talking about that knee that you've had done, they may be happy with it, but it's the left knee they haven't had done that's causing all the pain, and that's keeping them up at night. Publication bias. Only publishing positive findings, not negative ones. That is something that we are all guilty of. We don't want to say, oh, actually, all these 100 operations I did all went badly wrong. I'm going to tell everyone about it. So we tend to talk about the 100 operations that all went right. So how do we reduce bias? That's, again, a follow-up question. So randomization, mask blinding. So we talk about double blinding. Now we're talking about triple blinding, where so double blinding, the patients don't know what they're going to get. We don't know what we're doing. And also the people analyzing the data don't know which group they're looking at. And then we can also have age or sex match to reduce that confounding variables. And but sometimes we can't fully eliminate bias. So that's why we have to accept that. This is something that we haven't touched on yet, but this is something that comes up another popular question. Name some outcome scores used in orthopedics. So we all know about the Oxford scores, very, very popular. So I would recommend having it at the back of your mind, how you go through it. So you know it's 12 questions from 0 to 4 in terms of how you're feeling, and the top score is 48, and that means someone's got a normal knee or normal hip. And it's very much a functional score, and it's reliable and validated. That's a key thing. That's why, if you're going to talk about it, you want to talk about that. And it's also very good. It's used as a research tool, and we use it as a way of documenting change. So if you look at the NGR, where they send all the patients an Oxford knee score before their operation, 6 weeks after operation, 6 months after, and then a year after. So they're looking at that progression in terms of patient satisfaction. Again, validity, again, is important in terms of experimental value that represents a true value. And then reliability is something that can be reproduced from patient to patient and surgeon to surgeon. I've got this in my exam. Does anyone know what it is? Anyone want to talk about it, or shall I carry on? The reason why I offer this, because it's quite a dry subject. I don't mind talking about it, but you must be getting bored by now. Yeah. It's important you get a chance to talk about these things, not just yourselves, but also to others as well, so know how you sound. Box plot is something that's quite common, very popular. It's a convenient way of graphically depicting groups of numerical data through their 5 number summaries. So we've got the smallest observation, lower quartile, medium quartile, upper quartile, and largest observation. The box plot can either be drawn, in this case, we've done it horizontally, or it can be done vertically. It contains the middle, which this bit here and this bit here is 50% of the data, okay? The upper edge of the box represents the top 25, the 75th percentile, sorry, I get it right. So the top 25% or above, and then the lower line represents the 25th percentile, so everyone else below. And then the line in the middle typically is the median value, and it's not necessarily in the middle of the box if it's skewed data, for example, here. Okay, so we know median is the middlemost of the range, not mode, which is the most commonly occurring, or mean, which is average. The points outside the box represent the outliers. So again, this might be a very popular thing. They may show this there to you and say, what's this? And describe it. So you need to be able to talk about this in the exam situation. You can do this hopefully in under a minute, and then they can talk about other things, okay? All right, another thing they may also ask about, sorry, this is pictures from the Oxford slides, I haven't got rid of them, is what is a power calculation. So with that one, discussing power analysis. Again, we're not experts. This is something we talk to our statisticians about. It's a way to calculate how many subjects are needed in the study so that we can demonstrate it's statistically valid. The conclusions can be drawn, extrapolated to the rest of the population. That's the answer they want you to say. They might ask how you do it and what sort of things do you assumption. There are some good things about it, but I never really understood it, so I have to be honest with that one. Sorry.
Yeah, if I could say something,
Sure.
I don't think many people understand it, but I don't think you need to understand it for the exam. You could just say, I will ask statistician to make a power analysis for me.
If you understand it, you're looking at an 8, but trust me.
Exactly, yeah.
I got confused trying to explain it to myself once. Yeah. But the key thing is you need to have a power analysis at the beginning of any clinical trial. That's what they want you to appreciate, to know how big your study has to be to allow you to extrapolate your results to the rest of the population. I think that is what the level that we need to know. But if they ask you how you calculate it, it probably means you're doing well. So it's just, as I say, if you have an idea, have it at the back of your hand as your little ACE card. Not something to produce straight off, but just have it as an ACE card. A very popular one as well is screening programs. How do we go about doing a screening program? So we all know the World Health Organization from guidelines from '68, I hope. No, I can barely remember them. So the key thing is a disease that's important, a treatment that's available, a latent stage where it can be picked up and treated easily, a natural history that is understood, and agreed policy on who to treat. The test itself, there must be available to everyone, acceptable to the patient, sensitive and specific, and cost effective. So those are the sort of the key 9 points they want you to remember. It's a bit of a mouthful, but it does sort of, if you can do that very quickly, you've got at least a 6 in that situation. The idea of course, is obviously to catch the disease as early as possible so that any intervention doesn't cause too many problems and allows a patient to have a normal life afterwards. And the test itself mustn't make it be worse than actually the disease itself. That's we have to remember that sometimes. So then the next thing they might talk about is define sensitivity and specificity and accuracy, because that's something that becomes very important when we're looking at tests. So sensitivity, does anyone want to say what that is?
So David wanted to know if you have a simple, straightforward exam definition of sensitivity and specificity prepared for your Viva table.
Okay, I will define sensitivity as the probability of the test or the ability of the test to pick all those with a disease, and the specificity is the ability of the test to exclude those without a disease. The accuracy.
So yes, it could be a little bit more accurate. So they want to say the ability of the test to exclude false negatives. So, and yes, then that's sensitivity, and specificity, the ability of the test to exclude false positives. So yeah, it's not very snappy, but I think you got the gist of it. So that's great. So that's kind of the thing. And then the next thing is they want you to draw the table.
Yes, the 4x4 table.
Okay.
Or
don't worry, I won't ask you to do that one. It's mean to do it in this situation, but I don't. So bad, my computer doesn't want to do it. So this is what they want you to produce. So you ignore the truth at the top. So has the disease does not have the disease on one side, positive and negative. So has the disease, true positives, does not have the disease, false positives. All right, my computer's trying to switch myself off. And then underneath negatives, false negatives, and true negatives. And so sensitivity, as we said, is the true positives over true positives plus false negatives. So the ability of the test to exclude false negatives, so picks up everything except the few that are actually negative, okay? Then specificity, so we've got true negatives here, over true negatives plus false positives. So the ability of the test to exclude false positives. All right. And then I used to get very confused, to be honest. I used to get positive predictive value and negative predictive value with the wrong way around as well with those. But the key thing is it's true positives plus true positives over false positives. Okay, and again, all the negatives are for negative predictive value, just an aid to memoir. Okay, but this is something that they would like you to produce in the exam if you can. Practice doing it. It's very quick. You can do this in 30 seconds, and you can, as you're drawing, talk about it. It may sound mad to everyone when you're doing it, well, if you're doing it in the library, but it's good to talk about it as with any diagram you're doing. Talk as you draw, because you don't want to waste time. I won't film. Sorry. Yeah, next one. And then next one is talk about errors in a study. Again, that's something they might ask about. They may talk about a research project you did. What type of errors did you encounter when you were doing this? So they'll have different ways of asking this question, but generally they want to talk about errors for that one. So you've got the type 1 error, which is otherwise known as an alpha error, false positive. So thinking there's a difference when there isn't a true difference, and incorrectly rejecting the null hypothesis. This is usually by reducing or lowering the p-value. Okay, a type 2 error or a beta error, where the false negative, thinking there wasn't a difference when actually there was a true difference, and incorrectly accepting the null hypothesis. This usually is caused by having a small study, so it's too difficult. So if you've got 10 people, you cannot really extrapolate the difference. Whilst if you have 1,000 people, you're more likely to have a stronger power and hopefully overcome this. So a type 3 error, that's something that we rarely see, but correctly rejecting the null hypothesis, but incorrectly attributing the cause. Can sometimes happen, and often you see it when you see in the Daily Mail. One week the study says, what was it? I've forgotten. HRT gives you heart attacks. Next week they go, actually no, it doesn't. So don't ignore the last paper. But those are sort of things that we have to be wary of. Okay. And I think we talked about this earlier as well with Amjad, talking about survivorship. So it is quite a dry topic, but again, this is a Kaplan Meier curve. So the solid part of the line is the survival curve for the sample subjects. Again, talk about the y-axis and the x-axis. So x-axis is over time. Y-axis is the percentage of people or survivors with the implant. Okay, so how many? So you put 100 hips in. Hopefully at day 1, 100 hips don't need revising. However, at year 20, this situation, 60% have needed. 60% are still surviving. 40 need revising. Not a good prosthesis in this situation. The top line, if I can get this right. Typically, we have a 95% certainty of the overall survival curve of the entire population within the dotted line. So these two dotted lines, so that hopefully represent 95% of the people. Okay, so we will have some outliers. We'll have some in there. And this is the study of the outcome of intervention is plotted as we're going along. So every time we get an event, we'll lose some patients. It might be for deaths or maybe revision. So we have to include that when we're thinking about it.
David, can I just apologize? Just
practice talking about it. Again, talk in the mirror. There are lots of textbooks that have very good ways of defining it. So I would highly recommend to just have a go talking about it. Another question that does come up, again, they're talking about studies. So tell us about regression and correlation. So, regression, and these are sort of techniques or mathematical studies that we use to calculate how well a variable is associated with one another, and hence how one will change from the other. So linear regression and correlation are similar and easily confused, to be honest. In some situations, we end up doing them both. So correlation describes the relationship, whether there's a positive or negative relationship, and regression talks about the strength of that relationship between with regards to the variables. So you may very well have a graph, dot graph with lots of different, sorry, I don't have one, I apologize, but you will see them quite clearly where there are lots of little dots along the line, and you will notice that there is a correlation from the y to the x-axis, and the line will indicate, I draw on this, let me just draw this there. Okay, so you may have little graphs dots along here. Okay, and so there may be a correlation. So there's no true linear thing, but so correlation is there's a linear relationship with with the y and x axis, and then the regression is the strength of that relationship. I hope that comes across well. Okay.
Yeah, we can see it. It's okay.
Yeah. Okay. Now, those are the main questions when I went through all different papers and things like that. These are the main questions I think that come up regularly, but there are still things that you need to think about when you're doing this. As I said, I can't strongly recommend, I strongly recommend knowing your definitions and just saying them to yourselves. Okay. Or practice them with a friend beforehand, because the exam's only a couple of weeks away. There's some important ones, as I said, we've covered. So sensitivity, specificity. If you want, you can look at odds ratio, but power, know your incidence and prevalence and relative risk. Those are the sort of things that we could go into, but this will take an hour or so to do the whole topic. We're going to go about 20 minutes, and there are more things to go on about. I noticed we've got 8 minutes left. So I did have a hot seat question that we could do.
Thank you, David. That's great. I think you have amazingly managed to squeeze a lot in less than half an hour. Dry topic, you also, it's very challenging, and you did that very well. Thank you, David.
Is that fine?
It's really, it contained a lot more than I thought in the limited time. So that's very useful. So I think if you would like, we have a candidate, if you'd like to, unless Shwan wants to add something.
No, there's a lot of jumps about the Kaplan Meier, because a lot of questions came up, and just a few other questions as well came up during the presentation. So to reiterate, the Kaplan Meier is, if you're looking at the NJR data, for example, you want to find out the survivorship of a hip replacement. You start off with X amount of patients, which is 100%, and you keep adding to that on the left side of the graph. So always you have 100% at the start. As you move through the years, you get drops. These drops are revision of the prosthesis. Okay, they're not deaths, they're not other events, they're revision of the prosthesis. Sometimes they put dots in to signify other events, to try and show you how many, such as deaths, or to, for example, loss to follow-up and so on, when a patient became lost to follow-up, okay? So those, you need to know what those dots mean, and usually there's an explanation at the bottom for those dots. They're not always the same depending on what type of Kaplan Meier you're looking at. So just to make sure you all understand, those drops are the end result that they are watching for. So in the case of prosthesis, it's the presence of a revision. For example, in cancer, you could make it as a presence of recurrence. But if a patient dies without recurrence, that's a successful cancer treatment. Does that make sense, guys? I hope it does.
Yeah. Sorry if I got a bit confused there. Sorry, I'm running my brain.
No, it's a difficult topic, and sometimes you went through a lot, and getting those terms perfect the way you did was amazing. I'm impressed.
I think that was very good, David, and Shwan has explained and clarified points clearly, and that's why we hear all
There
of
was
us.
one more question, I think, from Amjad, because it seems quite relevant, but I'd be surprised if you do get asked in the exam. But just for the sake of explanation. Standard deviation is the number of patients that are in a curve 95% from the mean or median, which if it's a standard curve. 95% of the patients will fall within one standard deviation, okay? Two standard deviations is, I think, 97 or 98.5, I can't remember the exact number. Variance is a measure of how different the patients are from the mean. So, for example, if you've got a broad variance, that means you've got a graph which is very, if you can all see my picture, you've got a graph which is very broad, and the number of patients across the base is very high. If you've got a narrow graph, you've got a very narrow number of patients, and they're all very close within. That tells you how distributed those patients are in relation to the mean. And finally, standard error of the standard deviation, standard error of the mean is a measure of how accurate your study is. So it's a reflection of where your study stands in the normal population. So it's a very simple example. If you want to find out, is height related to cancer, just let's say, you decide to examine X amount of male patients, and you measure their height, and you measure the incidence of cancer in that group of patients. A good way to check if those group of patients you have taken as your study group reflects the population is to measure how far off the mean your group of patients is to the normal group of patients, to the normal population. Your own population group, you've got a big population, all males, you've got their mean height. You're also now taking a selection of those males for a study to see what incidence of cancer occurs at certain heights of patients. You measure the heights, and you've got a mean height for your group of patients. You also have the mean height for your general population. So that that's a measure of your study being reflective of the true population.
Thank you, Shwan. I think now we're running out of time. So I'd like to thank David again and Shwan for all the time they took in preparation. David for the nice presentation. I think this was popular again. Thanks to everyone who attended. We had 39 participants attending this presentation. Now we've had a short hot seat session earlier. We're gonna run another one.
Organizing this, I know it takes a lot of effort on your part. It's a lot of work.
Thank you for us.
Fine. Thank you, everyone. So I'll end this meeting now, and good luck, everyone. I'll keep you posted, and we will try to improve the technical part of the meeting next time.
And please do fill the feedback in, because it's quite important, that feedback for us. Okay.
Thank you. Okay, guys. See you.